Hello and welcome to the May 2026 HRO2 podcast. This is Jeanne E. Poole. I'm the editor-in-chief. The title of the first paper is A Functional Anatomic Mapping Protocol for Cardioneural Ablation Mechanistic Case Series. In this case series, the authors identify as a key finding that effective modulation of cardiac nodes occurred in all patients who achieved a heart rate increase of greater than 15%, a significant standard deviation of normal to normal interval reduction with no recurrence of syncope over a mean follow-up 13.4 plus or minus 3.2 months. It also noted that asymmetric vagal innervation was revealed. Left and right vagus nerves contributed differently to sinoatrial and atrioventricular node control, highlighting the importance of functional assessment over purely anatomic targeting. Next, they noted that critical interganglionated plexus pathways were identified. Connections such as left inferior ganglionated plexus to right inferior ganglionated plexus via the coronary sinus pathway for AV node control and left superior GP to right anterior GP for sinoatrial node control informed ablation extent and laterality decisions. And finally, they noted that feasibility of targeted physiology-guided ablation was successful in combining extracardiac vagal stimulation and endocardial high-frequency stimulation reliably mapped key pathways, enabling precise ablation while minimizing unnecessary lesions. The title of the next paper is Relationship Between Coughing and Bispectral Index-Guided Sedation During Pulsed Field Ablation or Atrial Fibrillation and its Impact on Midterm Outcomes. The author's first key finding is that during pentaspline pulsed field ablation, catheter-based pulmonary vein isolation under deep sedation, higher bispectral index values reflecting lighter sedation were associated with an increased incidence of coughing, whereas deeper sedation was associated with fewer coughing episodes. Second, younger age, higher body mass index, and higher maximum bispectral index value among all pulmonary veins were identified as independent predictors of coughing. And third and final, coughing during PFA did not adversely affect midterm freedom from atrial tachyarrhythmia recurrence in a propensity score-matched analysis. The title of the next paper is High Power, Very High Power, and Low Power Radiofrequency Ablation for Atrial Fibrillation, a Bayesian Network Meta-Analysis. First key finding is that in a Bayesian Network meta-analysis of 51 studies, which included 13,751 patients, both high-power short duration and very high-power short-duration radiofrequency ablation strategies were associated with lower atrial arrhythmia recurrence than conventional low-power long-duration ablation. Compared with low-power long-duration, recurrence was reduced with high-power short-duration with a rate ratio of 0.85 and very high-power short-duration with a rate ratio of 0.79. The very high-power short-duration versus high-power short-duration comparison was inconclusive. Next, composite in-hospital complications were comparable across the strategies. Fourth, high-power approaches shortened procedural time by 35 minutes versus low-power long duration at 34.4 minutes and very high-power short duration of 34.7 minutes. Very high-power short duration achieved the shortest RF delivery time, whereas high-power short duration achieved the shortest fluoroscopy time. Finally, ranking analyses suggest that very high-power short duration had the highest probability of being the best for efficacy with a ROC of 0.89 and RF delivery time with an ROC of 1, whereas high-power short duration ranked the best for fluoroscopy time. The author's final conclusion is that high-power short duration and very high-power short duration ablation strategies yield superior efficacy and procedural efficiency compared with low-power long-duration ablation while maintaining a similar safety profile. Next up is a paper titled Induction Indices During Ventricular Pacing as an Alternative Diagnostic Tool in Supraventricular Tachycardias by Dr. Ikenobu Mitsutani and colleagues. The first key finding is the induction ventricular atrial sequence distinguished atrial tachycardia, ventricular atrial ventricular from atrial ventricular node oriented tachycardia, or orthodromic reciprocating tachycardia, ventricular atrial ventricular. Second, the induction post-pacing interval minus tachycardia cycle length paralleled the conventional post-pacing interval minus tachycardia cycle length, and a corrected I-PPI TCL of equal to or less than 110 milliseconds differentiated septal ORT from AV NRT. Finally, combining these induction-based indices enhances differentiation of supraventricular tachycardia mechanisms when tachycardia is too brief for entrainment. The title of the next paper is Simplified Propofol-Based Deep Sedation by Electrophysiologists, Safe and Versatile for Pulsed Field and Thermal Ablation. These authors provide the following key findings. First, simplified propofol-based deep sedation can be administered effectively and safely by a trained team of nurses and electrophysiologists with access to anesthesiologic expertise on immediate call. Second, the deep sedation provides versatile sedation that can be tailored for both thermal and pulse field ablation. And finally, the simplified propofol-based deep sedation allows for short post-procedural time to the ward, which may reduce laboratory occupancy time and reduce the requirement of prolonged post-procedure observation. The authors conclude that in this study of 497 patients, the simplified deep sedation was feasible, safe, and effective in providing pain-free ablations across energy sources and arrhythmia types provided. 1. Careful patient selection. 2. Sedation by a dedicated and formally trained team of nurses and electrophysiologists. And 3. Established collaboration and availability of anesthesiologic expertise on immediate call. The next paper is titled Infections After High-Voltage Cardiac Implantable Electronic Device Replacements by Dr. Rossman Flang-Hoff and colleagues. First key finding is that overall 3 procedure-related infections were documented in their cohort, corresponding to an infection rate of 1% in a cohort of patients undergoing high-power generator replacement. Second, the use of an antibiotic envelope varied depending upon whether it was systematically applied to all patients considered high risk based on the Prevention of Arrhythmia Device Infection Trial score, or left to the operator's discretion. Third, applying the antibiotic envelope based on operator discretion may result in a more random use of the therapy rather than targeting individuals at the highest risk. And finally, the incidence of procedure-related infections after high-voltage cardiac implantable electronic device replacement can be kept at a low level, and guideline-based infection prevention measures are rigorously implemented. The title of the next paper is Conduction System Pacing versus Right Ventricular Pacing After TAVR, a Systematic Review and Meta-Analysis by Dr. Alexandru Diaconou. The first key finding is that conduction system pacing versus right ventricular pacing performance in patients requiring permanent pacing after transcatheter aortic valve or TAVR, CSP predominant left bundle branch pacing is associated with significantly shorter pace cures duration and higher follow-up left ventricular ejection fraction than RVP. Second, clinical outcomes. The use of CSP is associated with a lower risk of heart failure hospitalization during midterm follow-up, although no significant difference was observed in all-cause or cardiovascular mortality. Third, regarding safety and stability, CSP demonstrates comparable lead stability and sensing parameters to RVP, despite modestly higher capture thresholds at the time of implantation. And finally, clinical implication. These findings suggest that CSP is a safe and physiological alternative to RV pacing for post-TAVR conduction disturbances, although large-scale randomized controlled trials are needed to confirm the long-term clinical benefit. The next paper is titled Recommendations for Sharing Cardiovascular Implantable Electronic Device Data with Patients based on Clinician Interview by Dr. Carly Daly and colleagues. The first key finding is that data such as battery status and the presence or absence of episodes could be useful for patients with CIEDs to receive and understand from remote monitoring reports. The second, reasons for sharing data with patients include facilitating next steps in their care plan, improving confidence in care, improving understanding of their device and health condition, preparing for cardiology visits, improving symptom self-monitoring and medication adherence, and responding to patients' preferences for data. And finally, patient use, enrollment, and adherence of remote monitoring was identified as a key clinical care gap in the care of patients with CIEDs. The title of the next paper is Safety and Efficacy of Ultra-Low-Dose Fluoroscopy in Left Atrial Appendage Occlusion by Dr. Joe Demian and colleagues. First key finding is that ultra-low-dose fluoroscopy meaningfully reduces radiation exposure during left atrial appendage occlusion compared with standard fluoroscopy. Second, dose reduction is achieved through an echo-forward workflow, which is intracardiac echocardiography guided access navigation and transesophageal echocardiography guided implantation, rather than continuous fluoroscopic guidance. Third, ultra-low-dose fluoroscopy is associated with greater procedural efficiency with shorter fluoroscopy time and shorter overall procedure duration. Next, procedural success, acute safety, device-related outcomes, and clinical outcomes were comparable between strategies through follow-up. And finally, the approach preserves fluoroscopic bailout capability while keeping fluoroscopy use intentionally limited. The title of the next paper is Lean Body Mass is the Independent and Predominant Anthropometric Variable Associated with Atrioventricular Block by Dr. Ho-Lee Chun and colleagues. The first key finding is that in this UK biobank prospective cohort study, increased lean body mass was associated with a higher risk of second-degree AV block, third-degree AV block, and AV block-related pacemaker implantation in both men and women. Associations remain robust even after adjustment for various anthropometric variables, including fat mass. Second, increased lean body mass was also associated with a higher prevalence of a prolonged PQ interval, greater than 200 milliseconds, suggesting a relationship between lean body mass and AV conduction delay. And finally, the sex difference in the risk of the composite of second or third degree AV block was attenuated after adjusting for lean body mass, suggesting that sex differences in AV block risk may be partly mediated by differences in lean body mass. Next up is a paper titled PQRS-T ratio and the spatial ventricular gradient differentiate acute versus chronic left bundle branch block after transcatheter aortic valve replacement. The first key finding is that changes in cardiac memory over time can be used to differentiate acute, less than 24 hours old, from chronic left bundle branch block in patients undergoing transcatheter aortic valve replacement. Second, the vector cardiographic parameters, PQRS-T ratio, and spatial ventricular gradient, SVG, which reflect cardiac memory, differ significantly in patients with chronic versus acute left bundle branch block after TAVR. Third, a combined peak QRS-T ratio of equal to or greater than 2.7 and SVG Z component of equal to or greater than 15 millivolts per millisecond had 100% sensitivity, 98% specificity, and an area under the receiver operating curve of 0.99 for differentiating chronic from acute left bundle branch block. Finally, over long-term follow-up, patients with new left bundle branch block after TAVR that did not resolve transition from acute to chronic left bundle branch block VCG phenotype. Next up is a paper titled Fetal Heart Rate and the Neonatal QT Interval Results from a Large General Population Study by Dr. Tippy Quinn Lamb and colleagues. The first key finding is that there is no association observed between first trimester fetal heart rates and the neonatal corrected and uncorrected QT intervals. Second, lower second trimester fetal heart rate was associated with longer neonatal corrected and uncorrected QT intervals. Next, the association between fetal heart rate and neonatal QT intervals dependent on the gestational age at fetal heart rate assessment. The authors state that in conclusion, this study demonstrated a GA-dependent association between fetal heart rate and the neonatal QT interval, with lower FHRO2 values associated with longer QTC intervals. Although not a definitive screening tool, FHRO2 may offer early insights into neonatal cardiac electrophysiology. The authors note that follow-up studies are needed to determine whether these associations persist, progress, or affect long-term cardiac health. The next paper is titled Computational Analysis of Intracardiac Collision Risk and Optimal Site for Right Ventricular Leadless Left Bundle Branch Area Pacing, a Simulation Study by Dr. Jeanne E. and colleagues. The first key finding is that device length is the critical design parameter for intracardiac collision risk during leadless conduction system pacing, with collision risk increasing by 3% to 8% per 5 millimeter increment, primarily driven by right ventricular wall interactions. For contemporary leadless pacemakers, volume differences contributed minimal variation, less than 2%, and matched lengths. Second, the left anterior fascicle region emerged as the optimal target for leadless left bundle branch area pacing among clinically feasible sites, offering the lowest combined collision risk, less than 53% at device lengths less than 35 millimeters, while maintaining appropriate mid to upper septal positioning for effective conduction system capture. Third, tricuspid valve collision risk was determined primarily by implant location rather than device design, with pacing sites greater than 20 millimeters from the tricuspid valve annulus, substantially reducing tricuspid valve collision risk across all device types. And finally, substantial interpatient anatomic variability demonstrates that collision risk is highly anatomy-dependent, supporting a patient-specific computational modeling approach to optimize device selection and implant site planning for leadless conduction system pacing. The title of the next paper is Clinical Manifestations and Outcomes of Idiopathic Ventricular Fibrillation and Early Repolarization Syndrome in Adolescents, a multi-center cohort study by Dr. Sing-Ming Baek and colleagues. Key findings are that first, early repolarization syndrome showed a higher recurrence of life-threatening arrhythmic events and shorter LAE-free survival than idiopathic ventricular fibrillation in adolescents. Both early repolarization syndrome and idiopathic ventricular fibrillation in adolescents exhibited higher life-threatening arrhythmic events and recurrence rates than those reported in adult patients with the same diagnoses. In adolescents with early repolarization syndrome, early repolarization pattern location is a key prognostic factor, whereas in idiopathic VF supraventricular tachycardia is the strongest predictor of recurrent life-threatening arrhythmic events. In early repolarization syndrome, the early repolarization pattern, duration, pause-dependent dynamicity, and location are interrelated and collectively influence the prognosis. The title of the next paper is In-Hospital Mortality in a Large 7-Year Single-Center Retrospective Cohort of Patients Admitted for Ventricular Arrhythmia, Dr. Jeanne E and colleagues. The first key finding is that in this large real-world study of patients hospitalized for ventricular arrhythmias without ST segment elevation myocardial infarction, the overall mortality rate was high at 20%. Second, catheter ablation for ventricular arrhythmias had the strongest independent association with a reduced risk for in-hospital mortality, followed by the use of antiarrhythmic drug therapy. And finally, acute heart failure, cardiogenic shock, mechanical ventilation, and the occurrence of ventricular fibrillation were all associated with an increased risk for inpatient mortality. Next up is a paper titled Electrophysiological and Electrocardiographic Characteristics of Ventricular Arrhythmias Successfully Treated by Coronary Venous Ethanol Ablation by Dr. Lei Ding and colleagues. The first key finding is regarding efficacy. Among patients undergoing coronary venous ethanol ablation for ventricular arrhythmias, 69% achieved acute procedural success. For vein-specific electrocardiogram phenotype, first septal vein and left ventricular annular vein targets showed similar right bundle branch block-like morphologies, whereas anterior interventricular vein-related ventricular arrhythmias showed a left bundle branch block pattern with a QS and V1 and V2 and late precordial R-wave transition. Third, and regarding intraprocedural marker of effective ablation, a transient irritative increase in VA burden occurred in 44.8%, was more frequent and successful than failed cases. Safety profile, complications were limited to transient bundle branch block 9.5% and transient ST wave changes 2.4%, resolving with pausing and terminating ethanol infusion as needed. And finally, regarding efficacy, 4 patients had VA recurrence. 1 underwent repeat CBEA at the same target vein, and 3 were successfully managed with drug therapy. Next paper is Safety and Lesion Characteristics of Temperature Flow Control versus Power Control Modes and Radiofrequency Ablation, an in vivo study in swine. First key finding, regarding the superior safety profile, the study demonstrated a marked reduction in steam pop incidence with temperature flow control mode compared with power control mode, 1.1 versus 9.9%, with a particularly significant reduction observed during ventricular ablation, 3.6 versus 26.1%. Second, regarding maintained efficacy, under matched ablation index guidance, TFC mode, that's temperature flow control mode, achieved lesion dimensions comparable with those of the power control mode, specifically regarding depth and diameter, demonstrating that procedural safety is improved without compromising lesion efficacy. Finally, regarding pop recognition and risk sites, although power control mode was associated with silent steam pops that went undetected clinically, the temperature flow control mode maintained a significantly lower overall event rate, with the rare occurring pops being reliably identified by the operator and exclusively located in high-risk anatomic sites such as the papillary muscles. Next up is a paper titled Anticoagulation Alone versus Anticoagulation plus Antiplatelet Therapy in Atrial Fibrillation with Stable Coronary Disease, and meta-analysis of randomized trials by Dr. Ashish Yadav and colleagues. Key findings are that first, in patients with atrial fibrillation and stable coronary artery disease, oral anticoagulation monotherapy and oral anticoagulation plus single antiplatelet therapy showed no significant difference in cardiovascular mortality, myocardial infarction, or stroke. Oral anticoagulation plus single antiplatelet therapy was associated with significantly higher risk of major bleeding compared with oral anticoagulation monotherapy. And finally, in patients with AF, stable coronary artery disease, oral anticoagulation monotherapy appeared to be sufficient for long-term ischemia protection with a more favorable safety profile. The next paper is Limited Association between Septal Myocardial Involvement on PET Imaging and Conduction Disturbance in Cardiac Sarcoidosis by Dr. Brigitte Kazim and colleagues. First key finding is that conduction disease is common in cardiac sarcoidosis, but incompletely explained by abnormalities on positron emission tomography, or PET, or magnetic resonance imaging. 2. In particularly high degree AV block shows poor correlation with septal inflammation or scar on PET imaging. Third, multimodality imaging with PET and cardiac magnetic resonance imaging increases the detection of septal involvement. However, the imaging conduction abnormality mismatch persists. And finally, patients with cardiac sarcoidosis require vigilant monitoring for conduction abnormalities regardless of imaging finding, given that current imaging modalities cannot reliably predict or exclude clinically significant conduction system disease. The next paper has a title of Feasibility of Functional Substrate Mapping with a Novel Lattice Tip Catheter, Implications for Ventricular Tachycardia Ablation by Dr. Konstantinos Letsa and colleagues. First key finding is that functional mapping with a lattice tip catheter is feasible, enabling the recording of high-quality near-field signals displaying decremental properties. Second, decrement evoked potentials were co-localized with local activation time maps and the critical isthmus of the ventricular tachycardia. Third, despite its larger profile, this spherical catheter may permit effective entrainment mapping and/or pace mapping to accurately delineate the critical components of the tachycardia circuit. And finally, 81.8% of patients remain free of arrhythmia during a short follow-up period. The next paper is a Fellows Corner case report of a 74-year-old woman with hypertrophic cardiomyopathy. The title of this report is Ensuring Compatibility, a 3-stage screening strategy for leadless atrial pacemaker implantation with a pre-existing subcutaneous defibrillator. The next paper is also a Fellows Corner paper. The title is Interatrial Septum Dissection During Atrial Fibrillation Ablation by Atrial Septum Defect, a Rare Complication. This is a case of a 6-year-old woman with persistent atrial fibrillation who is admitted for catheter ablation. The next paper is a research letter. The title is Artificial Intelligence-Powered Electrocardiogram is Superior to NT-proBNP in Predicting Left Ventricular Systolic Function in Atrial Fibrillation with Rapid Ventricular Response by Dr. Omar Baik and colleagues. Key findings are first, risk stratification of tachycardia-induced cardiomyopathy remains poorly understood. The authors investigated the role of AI-powered electrocardiogram in predicting reduced left ventricular ejection fraction amongst patients with rapid atrial fibrillation. Second, amongst 11,801 patients with AF, the AI-ECG low ejection fraction probability cutoff is 75%. At a specificity of 96% and a negative predictive value of 98%, ruling out an LVEF of less than 35%. Third, AI-ECG was superior to N-terminal proBNP peptide in predicting an LVEF of less than 35% with an RLC of 0.72 versus 0.59 with an accuracy of 77 versus 47%. And finally, the author's study offers novel insights into the role of AI-ECG in guiding diagnostic and therapeutic decisions in suspected tachycardia-induced cardiomyopathy. Next paper, another research letter, is titled Mechanistically Guided Posterior Box Isolation Using Pace Capture, Resting, and Threshold Adjusted Voltage Mapping by Dr. Koji Kumagai and colleagues. First key finding is a mechanistically guided posterior box isolation strategy integrating pace capture testing and threshold adjusted voltage mapping enabled targeted identification of residual posterior wall conduction. Second, high-output pace capture testing unmasked functional conduction gaps not evident on conventional voltage mapping alone. Third, threshold-adjusted voltage mapping localized discrete high-voltage myocardial islands within the posterior wall. Fourth, this hybrid strategy achieved posterior box isolation with a limited number of additional lesions. And finally, short-term arrhythmia-free survival was higher with a mechanistically guided approach than a conventional activation-guided strategy. The next and last paper is another research letter. The title is Pulse Field Ablation using a large tip focal contact force sensing catheter with three-dimensional mapping integration. 12-month outcomes from the Omni-AF pilot phase by Dr. Dinesh Sharma and colleagues. The first key finding is that the Omni-AF pilot phase showed a strong safety profile with zero primary adverse events, zero magnetic resonance imaging detected cerebral emboli or lesions, and zero new or worsening neurologic deficits. Second, high effectiveness was demonstrated, including 100% acute procedural success and 90% freedom from primary effectiveness failure at 12 months. And finally, the electroanatomic mapping integration supported minimal fluoroscopy workflows with a median fluoroscopy time of 0 minutes and 56.7% of cases performed without fluoroscopy. This ends the podcast for May 2026. Thank you all for listening. We all really appreciate it. Thank you for your support of the Heart Rhythm O2 Journal. And I'll be signing off now to talk with you again next month.